Thank you. I'd like to thank the organizers for inviting me here today. So the disclosures are that the trials I'll present were both sponsored by the NIH. I'll discuss intracerebral use of alteplase or TPA, which I'm sure doesn't faze this audience. Okay, so the hypothesis that you can remove large volumes of clot from the brain early and improve functional outcomes is based on models like this, which propose an inflammatory reaction surrounding the hematoma with the introduction of plasma proteins, toxic products from red cells, and a variety of inflammatory cells, which lead eventually to signal pathways with apoptosis and neuronal death at the end. And although this sounds very intuitive, currently in the United States at least, craniotomy and minimally invasive surgery for ICH are only used in about 10% of cases. Now, if you look at Asia, it's a very different story. Minimally invasive surgery is used far more frequently, and in fact, the Japanese stroke guidelines do endorse surgery for ICH. The variety of techniques that are now available, which can broadly be dichotomized into those with stereotactic approaches and thrombolytics, and those with endoscopy and various adjuncts. And some of those adjuncts have not yet been validated. So the CLEAR and MISTIE programs really both had the primary hypothesis that removal of IVH in the ventricle and ICH through these procedures, which both involved delivery of thrombolytics, would alter functional outcomes in patients with very large IVH, as was studied in the CLEAR trial, and very large parenchymal hemorrhage, which was studied in the MISTIE trial. And these form part of the spectrum of ICH and IVH, as you see on the left. Now, these were both explanatory trials, which aimed to evaluate the efficacy of the intervention in a well-defined and controlled setting, to be distinguished from pragmatic trials, such as the STITCH trials for craniotomy for ICH, which looked at effectiveness of the intervention in routine clinical practice. So the CLEAR-3 trial enrolled 500 subjects in 73 sites, and all the patients had less than 30 mLs of parenchymal blood clot. They all had a clinically placed external ventricular drain with third and fourth ventricular obstruction, leading to hydrocephalus, and they were randomized to either alteplase or saline through the ventricle, up to 12 doses over 4 days, and these were all hypertensive hemorrhages largely, with structural lesions excluded. There was a significant impact on mortality, 50% reduction in the odds of being dead at 1 year, in absolute terms, a 10% reduction with a number needed to treat of 9. However, the primary outcome, modified Rankin 0 to 3 at 180 days, was neutral, only a 3% shift. And the critique of the trial was that the mortality reduction came at the expense of an excess of modified Rankin 5 patients, difference of 9% between alteplase and saline. If you look at the extended Glasgow outcome scale, the number of truly vegetative patients was only about 3% and not different. And we've made the argument that these modified Rankin 4 and 5 patients, if you look at the quality of life scale, which we did using the EuroQoL, which is a visual analog scale, at 1 year, you do see a lot of variability, which you might not expect. And there are a fair number of patients in the upper half of the happiness spectrum. We also saw a 10% improvement in patients who were at home or in rehab locations at the end of 1 year in favor of the alteplase group, which was significant. And in terms of safety, this also appeared to favor the alteplase group in terms of mortality, bacterial ventriculitis, and there were 14% fewer serious adverse events in the alteplase-treated group and no increase in symptomatic hemorrhage. Now, the technical nuances of the trial. So first of all, if you had a very small hemorrhage in the ventricle, you didn't appear to benefit. But if you had more than 20 mLs of blood on the right-hand side, there was in fact an adjusted effect size of 9.6% in favor of good functional outcome, and that was significant. Secondly, there was a large variance in the amount of blood clot that was removed from the ventricle. So most practitioners stopped the alteplase infusion after they had achieved clearance of the third and fourth ventricle, such that only about a third of the patients in the alteplase arm had removal of 80%, which was one of the goals of treatment, and only 10% in the saline arm. And it did so happen that we saw an increase in the probability of a good outcome with the extent of IVH removal. But that amount of removal had to exceed 80 or 85%, and that was true across all initial baseline IVH volumes. So this is sort of a dose-response curve showing that as you go from less than 20% removal to greater than 70% removal on the far right, you see a decrease in mortality, the red bars, and an increase in the proportion of good functional outcome patients. Catheter position was also important. So in patients treated with single catheters in the ventricle, if you place that catheter on the same side as the dominant IVH clot, there was faster blood clot removal than if you had a catheter on the contralateral side, which is typically the location these catheters are placed in order to prevent early obstruction. Similarly, in patients who had greater than 20 mLs of blood clot, if you place bilateral EVDs, one on each side, and dosed both of those EVDs as opposed to a single catheter, there was faster removal of blood clot, which is not hard to imagine. Now, the MISTIE 3 trial enrolled 499 subjects at 76 sites. All of these had greater than 30 mLs of blood and did exclude patients with massive IVH. They were randomized to either the minimally invasive surgery procedure or to standard care. And again, structural lesions were excluded by CTA or appropriate imaging. The surgical task involved CT-based navigation to locate the clot, aspiration of as much clot as possible, and then placement of a soft catheter down the longitudinal axis of the clot at least 2/3 of the way down. Then we administered TPA up to 9 doses, 1 milligram every 8 hours, until the clot size was reduced to less than 15 milliliters as determined by a daily CT scan. So the surgery takes about an hour, and the median clot size did reduce from about 45 mLs down to about 12 mLs, with a median of 4 doses of alteplase. The treatment variables were similar between the two groups, and with the exception that the number of high ICP and low CPP events appeared to be lower, or appeared to be in favor of surgically treated patients in those who had ICP monitors. Again, there was a mortality advantage. The adjusted hazard ratio was 0.67 over the full year of follow-up. And unfortunately, the primary outcome, modified Rankin 0 to 3 at 1 year, was not significant, only a 4% shift towards better outcomes with surgery. Mortality reduction was 6%, and the extended Glasgow outcome scale distribution looks similar. In terms of safety, the minimally invasive surgery procedure did not increase mortality, symptomatic hemorrhage, or bacterial infection, and in fact, the early mortality in the first week was significantly lower in the surgical group. Now, this graph shows the probability of a good functional outcome with respect to the clot remaining at the end of treatment. So for both large clots greater than 45 mLs, which is the red curve, and the green curve for smaller clots, you see that as the clot remaining decreases, your probability of a good outcome increases. And at the extreme, when you start looking at this green area below the to the left of the hatch line, below 15 mLs, we see a significant increase in the probability of a good outcome by 10% for each additional milliliter of hematoma removed. And if we look at only the patients in the surgical arm who had less than 15 mLs remaining and compare them to controls, there was a 10.5% difference in good functional outcomes in favor of the surgical group. Again, we saw a dose response with respect to having greater amounts of hemorrhage remaining, up to greater than 35 mLs, being associated with higher mortality and lower probability of good outcome. The thresholds for mortality benefit were a little bit lower than or higher than for functional outcome benefit. So if you had less than 30 mLs of blood clot remaining and over 53% clot removal, that was associated with a significant improvement in mortality. Surgical training has become a big issue, especially now with the industry-sponsored device trials that are ongoing. In MISTIE 3, we did require 3 pre-qualifying procedures and performance of a training module. And we did see a training effect in the sense that surgeons who had more than 4 prior trial cases and sites who had more than 8 cases never had more than 30 mLs of remaining clot volume at the end of the procedure. So the average clot volume at the end of the procedure, and that's about 4 to 5 days out after the alteplase infusions have been given and the catheter has been removed was 15 mLs. There were, however, 11% of cases in the surgical arm with greater than 30 mLs remaining, and that was important for mortality. And there were a little over 40% with greater than the 15 mL goal remaining, which was important for functional outcome. So in conclusion, the care for intracerebral hemorrhage with these minimally invasive techniques appears to be no longer futile. In the trials that I presented, which are some of the most severe ICH patients, 80% of the patients survived, and half of the patients who received these procedures were independent at 6 months. These trials were the first description, really, of the thresholds or benchmarks for success of the surgical tasks that would be needed to improve functional outcomes. But generalization of this performance is obviously going to require a lot of focus on technical nuances and more experience. So, although we think we understand to a certain extent what volumes we need to recommend these types of procedures for both the IVH and the ICH patients, and some of the surgical strategies that would be required to achieve the amount of reduction needed for functional improvement, I think there are a lot of factors we still don't understand. We don't have a good grasp of timing of surgery, clinical presentation that would benefit in terms of GCS, comorbidities, perhaps even things like cerebral small vessel disease that may impact long-term cognitive impairment. And then on the surgeon side, training aspects and device type, which type of device is right for which clot. Thanks very much.